Hello, everyone. My name is Jim Seberg, and I'm the Assistant Director for the Drexel University Medical Cannabis Research Center. Today, we are happy to be joined by Dr. Tom Marcotte of UC San Diego's Center for Medicinal Cannabis Research. Dr. Marcotte is also a professor of psychiatry at the UC San Diego School and also the co-director of the MCRC, which has conducted cannabis clinical trials for almost 25 years. He's the principal investigator on studies for addressing the effects of cannabis on driving ability. He's collaborated with law enforcement on studies, both laboratory and on-road, regarding officer detection of cannabis-related impairment, and served on statewide impaired driving task forces, as well as national panels, such as the Transportation Research Board. He has participated in symposia and presented work regarding traffic safety too, among others, law enforcement, forensic toxicologists, judicial, and traffic safety advocacy groups. He has served on a number of journal editing boards and is a lead editor for the book of Neuropsychology of Everyday Functioning. Without further ado, I'll pass it over to Dr. Marcotte, who will be giving a great presentation on cannabis and driving.
Thank you very much, Jim. So I very much appreciate the opportunity to present to your group today. So I'm going to be talking a little broad ranging in terms of looking at some of the work that we've done specifically, as well as broader work in terms of driving performance following cannabis use, officer observations and field sobriety tests, and messaging as well. So it's kind of a mixed presentation where some are more general findings, and then I go into some detail on some of our studies, thinking that the audience might find it interesting to see how we go about doing this work. So as you all are fully aware, there's been sort of a dramatic increase in the amount of legalization of cannabis, both for recreational and for medical use. The shift in public opinion occurred starting in the 80s and then sort of really came to effect over the last 10 or 15 years. As of right now, we have 24 states that have legalized adult use or recreational use, as well as 38 that have legalized medical use. As you're all probably aware, we know that cannabis has psychoactive effects. People use it for the high, but it also has some negative impacts in terms of cognition. This can be seen in reduced learning and attention, processing speed, and psychomotor abilities. In general, the driving research has shown that people who are under the influence have delayed reactions, poor lane tracking, so they tend to swerve in their lane, reduced judgment of speed and distances, and this tends to be dose dependent. The more THC in your system, the worse you do. In general, we'll talk about it in details. There's also evidence that people exhibit tolerance, that there is less prominent or no effects on cognition in people who are the most frequent or heavy users compared to less frequent users. And then very different from alcohol, users of cannabis in general as a group are more likely to judge themselves to be impaired, are more cautious when driving. They keep a greater headway from the car in front of them, drive more slowly, may be more reluctant to pass an oncoming car. Doesn't mean they're a better driver. It means they're a different driver than someone under the influence of alcohol. People still get stopped for speeding, etc., which may relate to cannabis, may relate to personality issues, and so forth. I'm going to talk a little bit of detail about our study that we completed a couple years ago. This was by far the largest study looking at cannabis use and driving performance. It was published in JAMA Psychiatry in 2022. For this study, we recruited 191 regular cannabis users, so they had to use at least 4 times in the last month. So it was a range of people used daily and multiple times a day to people only used once a week. This was a parallel design, which means we took the 191 people and randomized them to either get placebo, a 5.9 THC cigarette, or a 13.4% THC cigarette. You'll see a lot of studies that are crossover studies where people are in the placebo condition, the THC condition. But one thing that happens when you do that is people figure out what condition they're in, right? As in our study, 50% of the people who received placebo thought they got the real thing. But in a crossover design, the people quickly figure out whether they had THC or placebo. We also wanted to have a really large sample size for generalizability. And the studies that do these crossover designs often have a lot of attrition. People drop out. They'll do this for a few days, but they don't want to do it week after week. For our study, then, they would come in, they get some training, they would smoke, or they do a driving simulation, they'd get some blood, saliva, oral fluid assessments, etc. They would then smoke either placebo or THC and then drive on the simulator for 4 more times. For this study, importantly, we did what's called ad libitum smoking. So we told them to smoke the joint or cigarette the way they do at home to get high. Another approach is to give them a certain amount and try to give everyone the same amount. In our case, we really wanted generalizability. We did not want someone to say, well, that was a great study, but I would never get that high and drive. So we wanted to let people choose their level of highness. The cannabis we got was from the University of Mississippi. It's what was available at the time, and for the most part is still all that's available for research. These are just some examples of the simulation. So we put people through a bunch of different scenarios: residential zones, business zones. They had to do freeway merging and get quickly across the freeway and exit the freeway. This was one that law enforcement told us would be very sensitive. Distracted driving, so they drive straight down the road. They have this task off to the side on the iPad where they have to take their eyes off the road and identify which circle is a different size than the others. We had left turns across oncoming traffic, yellow light dilemmas. Is it safe to go through a yellow light? And then very few crash avoidance situations. So important to us, we did not want people to feel this is game-like, to be hyper-vigilant. Oh, when's Dr. Marcotte going to throw something at me again? We wanted actual crash avoidance situations to be rare. What did we find? So this is looking at what we call the composite drive score. So we took some of the more sensitive measures in driving simulation. Standard deviation of lateral position, which means how much do they swerve down the road? How well do they follow a car in front of them? How accurate are they on that divided attention task? And merge them into what we call a composite drive score that sort of captured the overall performance on the measure. On the y-axis is the change in composite drive score from before they smoked to right after they smoked, about 30 minutes later. So a higher score indicates worse performance after smoking. And as you can see, the THC group did significantly worse, a P of 0.0003, than the placebo group. And there's clearly a group of people who did much more poorly on this driving simulation after smoking. But what you also see is that a lot of people in the THC condition did equally as well as the placebo group. So it's very hard to determine what is quote unquote impairment on an experimental measure. But based upon the distribution we saw in the placebo group, we estimated that about 45% of people in the THC group would be called impaired. So clearly at the group level, it's impairing, but when you look at individuals, not everyone became significantly impaired, again, on our simulator. So what happened over time? On the x-axis, you see the minutes after smoking, 30 minutes, hour and a half, 3.5, and 4.5 hours. On the y-axis, you see this change in composite drive score. A higher score indicates you did worse than the baseline performance before you smoked. And then in yellow, we see the placebo group. We see the 13.4 and 5.9% groups. So a few takeaways from this. First of all, here's the effect we saw earlier where the THC group did significantly worse at 30 minutes following smoking. And then at an hour and a half, they were still doing significantly worse than the placebo group. And then at 3.5 hours, they were doing much better. 4.5 hours, they were in essence back to baseline. And so the effect was really lasting. This is, again, inhaled cannabis. And I should be clear, too, that these people were to abstain for 2 days prior to the study. We checked them via oral fluid, which isn't perfect, but is about all we have available to tech for recent use. So at least in this group, about 3.5 to 4.5 hours after smoking a single joint or cigarette, they were recovering and back to baseline performance. The other takeaway from this is, as you can see, the 5.9% in green or the 13.4% in blue did not matter. So the amount of THC content you got in your joint was irrelevant. People would self-titrate and they would find the level of highness they wanted, whether it was a higher THC content or a lower THC content cigarette. What we found also when we look at blood levels was that actually the 5.9% got a little bit higher THC into their blood compared to the 13.4. So it's all in the way that you smoke it, how deeply you draw it in, how long you hold it in, etc. But in this case, at least, sort of higher THC content did not mean more impairment. So what about tolerance? I'd mentioned earlier that people who are frequent users often develop tolerance to THC and it affects them less. We examined this by looking at all 191 people, or in this case, we were looking at the 128, and distributed them in terms of how much THC exposure do we think they had in the last 6 months. So how frequently they use, how much do they use, when they use, etc. Obviously, it's a ballpark estimate, but it is what it is. And so we then split those into three groups. We took the whole distribution of THC exposure and then dividing those to the lowest quartile, the lowest 25%, the highest 25%, and then the medium or average group, sort of the 25th to 75th percentile. So we sort of have the two extremes and then kind of the middle ground. In this case, on the y-axis is how much THC they had in their blood right after smoking. And as you can see here, the most frequent users on the high side here had significantly higher THC concentration than those who were in the middle, who were higher than those who were less frequent and less intense users. We then looked at these three groups and looked at their change in their drive score. And as you can see, there was no difference between the three groups. So those people who were the frequent users had higher THC concentrations, did just as well as those individuals who were less frequent users and had less THC. So there's clearly evidence of tolerance here, right? They could have much higher THC concentrations and do just as well as other people with lower THC concentrations. But what this also shows is that they did no better. So they had behavioral tolerance, but then they got enough THC into their blood that they performed just as poorly as people who had less THC in their blood and were less frequent users. So clearly there were signs of behavioral tolerance, but that was offset by the fact that they got more THC in their system as they sought to get a level of highness. What about their self-perception? Are they safe to drive? X-axis, we're seeing the time points. The left-hand side, we see the composite drive score. What we're looking at here is how impaired are you to drive? So on a scale from 0 to 100, we asked them, how impaired are you? As you can see, they were moderately impaired at 30 minutes. They felt it wearing off at an hour and a half, felt better at 3.5, and better at 4.5 hours. We then asked them, well, would you drive? In this state, this is reporting those who would not drive in their current condition. So about 50% at 30 minutes said, I would not drive. That dropped at 30% an hour and a half and so forth. If we recall back on the slide we just talked about on the composite drive score, here we're looking at the left-hand side. Remember, in the composite drive score, they did significantly poorly at 30 minutes. They were still having trouble at 90 minutes, and then we started seeing recovery at 3.5 and then 4.5 hours. So particularly concerning is this hour and a half mark, right? This is a time when, at least objectively on the simulator, people are not doing better, but they perceive that it's wearing off. And even those people who are very conscientious at the beginning of the post-smoking period are more likely to go on the road, even though they may not be showing actual objective improvement. So this is a particularly important time for public messaging that people may feel it's wearing off before it's actually wearing off. The risk of this perhaps comes across in this slide. So as you recall, very briefly, you saw this person doing this task on the iPad off to the right of the screen. So they have to take their eyes off of the monitor and look down to the iPad. There's a tendency for people to sort of drift to the right on their steering, right? As they're reaching over to touch, they drift to the right. What we see here in yellow is the placebo performance, group performance, and in green is the THC group. And as you can see, during the pre-smoke and the 30-minute mark, there were no significant differences between the group in terms of how much time they spent on the shoulder of the road. So they didn't necessarily crash, they didn't go all the way off the road, but they tended to swerve enough to actually leave the roadway. And the only significant time point is this hour-and-a-half point, where at least one could hypothesize they are feeling the effects are wearing off, they're less attentive, and they're more likely to make mistakes. Um, so. What is the relationship between THC in the blood and driving performance? This is looking at blood THC concentrations in the x-axis, change in drive score between pre and post smoking, and this is the correlation. As you can see, basically there is none. So it all is what is happening in your brain, not in your blood. This replicates other studies as well. This is a great graphic from Marilyn Hustis from many decades ago, but really gets across kind of what's going on here. This is referred to as counterclockwise hysteresis. So on the x-axis is the amount of THC in the blood. On the y-axis, in essence, is or how high do you feel? And this goes in this direction counterclockwise. So excuse me. So these are the minutes post smoking. 1.8, 4.5, 6 to 10 to 12, hour and a half, and so forth. What you can see here is right after smoking for the first 10 minutes, THC concentrations are going up, up, up in the blood, and the person's feeling higher, so it's going up on the y-axis as well. So there's this very brief concordance between THC concentrations going up and a person feeling high. What then happens, though, is that THC concentrations drop like a rock. So about 90% is gone within the first hour, hour and a half. And that's because the THC is distributing. Unlike alcohol that stays in the blood, THC is distributing to fatty tissues, including the brain, and very quickly is leaving the blood. And then over the next few hours, the highness starts wearing off. But these people are high during this time. So why it makes it so hard to look at THC in blood and impairment is because very soon after smoking, someone can have a high THC concentration and be very high, but they can also have a low THC concentration and still be high, and they can have a low THC concentration and not be impaired. So it's very different alcohol than alcohol that has sort of a linear relationship. As the blood alcohol or breath alcohol goes up, people become more impaired. As it drops down, more or less, they become less impaired. That's not how THC works in the blood. Now, this differs by route of administration. So on the left-hand side, we're looking at inhaled cannabis. In green is THC concentration. This is what we just looked at, very high early on and then drops very quickly. In the dashed line is 11-hydroxy, which is a metabolite, a psychoactive metabolite of cannabis. And we see a little tiny bump here in the inhaled part. It doesn't really go through the liver, so it is a metabolite that happens when THC goes through the liver. With oral administration, however, which are edibles or pills, we see that there's a very little bump in THC. So THC does not change much when you take an oral, you use an oral administration method. What does go up is 11-hydroxy. So it goes through your stomach, goes through your liver, gets metabolized into 11-hydroxy, which is psychoactive. And as you can see here, this dashed line starts rising over the first hour or two and then lasts for a very long time. So as you're all probably aware, when I talk about inhaled cannabis, people can get high very quickly, usually wears off in 3, 4, 5 hours. With oral administration, it takes longer to become high or impaired. It may take an hour or two, but then it lasts much longer, up to 6 to 8 hours. So it's very much dependent upon your route of administration. I'm going to comment a little bit about per se laws. So per se laws, of course, mean that, if you test at this certain nanogram per mil, you're considered driving under the influence. In the case of cannabis, it's nanograms per milliliter. In case of alcohol, it's breath alcohol concentration of 0.08 in most states in the United States. This is an important study because in this study, they looked at 602 cases where a drug recognition expert, this is kind of the top cop when it comes to impairment, determined that a person in the field was impaired due to cannabis only, and arrested them. They then took their blood concentrations and examined what they got when they got back to the lab. As you can see here, the median value, sort of the midpoint of the level of impairment, was 5 nanograms. So a number of states in the United States have a 5 nanogram per se limit, which means if you're above 5 nanograms, you're considered driving under influence. And that is sort of the purpose and the intent of the law. But what they also encounter is that law officers will often feel a person is under the influence and impaired at below 5 nanograms, which is consistent with kind of what we looked at before. You could have low THC concentrations and still be impaired. And in this study, about half the people were below the 5 nanogram mark. So laws that were intended to say, hey, if you're above this, you're under the influence, that simplifies it, like in alcohol, also complicated it because now prosecutors are having to convince juries that someone can be below 5 nanograms and still be impaired. And that has sort of become the bane of existence of prosecutors. I think for the most part, prosecutors are not in favor of per se laws when it comes to a nanogram cut point, at least. In addition to being impaired at low nanogram measurements, as you may know, THC hangs around in the blood for a very long time, particularly in frequent users. So this was a study in which they took 30 participants who were very heavy users. These people use multiple times a day for many years, and put them in a hospital and kept them captive, more or less. Obviously, they could leave if they wanted to, for 30 days. But this is showing different people how detectable they were at different time points. So this is day 1, day 2, day 3, and the median THC concentrations in the max. And what you see here is over 7 days, the median value was still about 1 nanogram. So they had not used for many days. For the most part, well, clearly acute impairment had worn off, but they were still testing positive. So I mentioned earlier about the 5 nanogram cut point. There are states that have zero tolerance per se laws who say if you have a 1 nanogram in your system, you're considered driving under the influence. One of those happens to be this state right here, which is Pennsylvania, which sort of has a conflicting message. So they will say medicinal cannabis is okay, but you cannot have any THC in your system if you're driving an automobile, which on the surface of it may make sense, but in reality, because of how THC is processed in the human body, it in essence means if you're a regular user, say you even use low dose for neuropathic pain on a daily basis, you will virtually always test positive anytime someone does a blood draw on you and risk being in violation of state law in terms of driving under the influence. What about driving in people who've abstained? So this is that same 191 people that I talked about earlier. And in this case, we were saying, okay, during their baseline visit, before they get the active treatment of THC or placebo, are they showing signs of impairments? They've now abstained for 2 days or more. Is it the case that people are more regular users who abstain more frequently? Some had not used for 5 days. Do these people show some residual effects of cannabis use. So even though it's kind of low level THC, is it the fact that their frequent use has resulted in impaired driving performance? In the left-hand side, we're looking at all 191 people. For simplicity, we're just looking here at how many days they use per week and the composite drive score at baseline. And as you can see, there's no correlation. We could not find any evidence in these 191 people that the more frequent users before they actually smoked cannabis were doing worse on the simulator than less frequent users. Now that's within users. So we also had a small group of people who were non-using controls from another study we'd look at. And again, on the y-axis, we're looking at the drive score. On the x-axis, we're looking at the most frequent users out of those 191. These are people who use daily, multiple times a day. So we're trying to get one extreme. Who are the heaviest users? Compare those to the non-using controls. And as you can see here, we see no difference in driving performance. So at least in our studies, no matter how hard we look, we cannot see any kind of ongoing residual effects on driving performance, which is an overlearned behavior and something that we do all the time. Now, we don't have a lot of crash avoidance situations. We are not doing cognitive testing. So cognitive testing shows there may be some carryover, but at least in an everyday activity, we're not seeing it in our study. How do we go about identifying impaired people on the roadway? So we know it's a risk. We know a subset of people who use cannabis may be very dangerous on the road. How do you identify those folks? One approach is to use the field sobriety test. These are all the ones you've seen on TV, etc. I won't go through all of them, but basically it's, walk straight ahead, turn around, walk back on a straight line, stand there with one leg held in the air for 30 seconds, touch your finger to your nose with your eyes closed. A lack of convergence refers to an officer taking, for example, a pencil and moving it close to your nose and seeing whether your eyes converge or whether you have problems and one wiggles or does not do that. The modified Romberg test is a test where they have you stand still with your feet together, tilt your head back, and let the officer know when 30 seconds have passed. So a few of these have been validated for alcohol. Interestingly, they were validated based upon BAC levels, not really on impaired driving, but really can officers determine your BAC level based upon your performance on some of these measures. They're increasingly applied to other conditions, including cannabis use. But a number of the studies that have looked at field sobriety tests have had significant limitations, right? So they have very small sample sizes. In most cases, an officer did not administer it. A research assistant was trained how to do it, and so they administered it, but it's clearly not someone who has years and years of experience in the field. These were often crossover designs where a person would see the FSTs repeatedly, which of course removes or limits their sensitivity if you really learn the measure. And sometimes in the interest of trying to get rid of any practice effects, which we actually show occur, they would give an FST before they administer the drug. So now the person's been exposed to it in a non-intoxicated situation, and now when you're exposed to it, it could lessen the sensitivity. In general, the studies concluded that FSTs are not sensitive to impairment. We examined this by taking 184 of those 191 people who did all the driving simulator and have them be evaluated by a drug recognition expert instructor, no less. So these are the top cops. They have 170 hours of training. They have field experience. And we use the instructors to do the field sobriety test. We always made sure the first evaluation happened after treatment, so they didn't get exposed to it when they were sober. And then we did these field sobriety tests. How did they look roughly 70 minutes after smoking? So we did find that the THC group had significantly worse performance on the FSTs, and the officer overall, based upon just FST experience, would call the person impaired. This was significantly higher than the placebo group, so the FSTs were sensitive to THC. On the other hand, the officers called 49% of those in the placebo group FST impaired. So this is not seeing driving performance. This is not doing extensive interviews. It's just based on FSTs and a little bit of interaction. But But obviously, this is concerning. We don't want everyone here in the audience, half of you, to be called impaired on the FSTs. So we did a deep dive to see, can we find anything that differentiates those in the placebo group who are called impaired or FST not impaired? We looked at demographics, age, sex, education, race, ethnicity. We looked at cannabis use. Is it possible that more frequent users were more likely to be called impaired on the FSTs or have poor performance compared to less frequent users? We looked at amount of exposure over the last 6 months. How long had they been abstinent before doing our study? We looked at medications with CNS effects. We looked at perception of treatment effects. So I mentioned earlier that 50% of our placebo group thought they got real thing. UCSD may not have given them very good cannabis, but they got real cannabis. And is it possible that those people thought they were stoned and so acted stoned? And did this relate to how high they were feeling? Well, in fact, none of those things explain the difference between the two groups. So while 50% of the people thought they got the real thing, that did not overlap with those who were called impaired by the officers. One of the limitations cited by toxicologists was that we only did screening for a urine screen, which is not the equivalent of doing a DUID or driving under the influence drug screen that they would get in a forensic lab. So we actually went back, pulled samples, screened for 300 different drugs, and found 25 people who had drugs that could affect them. Some were self-reported, others not. Some were street drugs. Removed those people, and it made no significant difference. We still had 45% of the placebo group called FST impaired, even when you removed those people. Now, it wasn't all bad news for law enforcement, the field sobriety test. In this case, in addition to it being sensitive to THC, we have some other analysis showing at the group level it's sensitive. There was a relationship between performance on the FSTs and driving simulator performance, in that those who were impaired on the simulator actually had worse FST performance, both when we took the whole group of under 91 people, as well as some were more sensitive perhaps in the THC condition. So there's some positive findings, but obviously the placebo group impairment rate was not very acceptable. I'll switch gears for a second here. So that's sort of what we've done, looking at acute administration and controlled studies to try to understand the relationship with cannabis use, driving performance, and law officer detection. We're also interested in sort of what the public thinks and what are their opinions. We've done a number of very large studies. This is with Dr. Linda Hill, who's in public health here at UCSD. One large study looked at 5,000 Californians and their attitudes about cannabis in general, medicinal use, etc., was one component looking at driving performance. More recently, we just completed a study funded by the AAA Foundation for Traffic Safety, looking at different states around the country and doing surveys of their populations. So in this case, we looked at 8 states, 2,000 participants, about 250 per state, and identified legal recreational states, those that were legal for medicinal only, and then those where cannabis was illegal. We did some, basically sampling that tried to make sure that it represented their state population in terms of demographics, and in this case required people to be regular drivers and cannabis users at least modestly frequently. We also asked them, in addition to their driving behaviors, how long they wait, etc., we asked them about their experiences with law enforcement. One of the findings that came out of this was that 29% of the people feel an officer could detect if they're under the influence of cannabis, but many did not. So almost half thought an officer could not detect if they're stoned, and about 25% were not sure. So this is in contrast to studies that have shown that about 70% of the people asked about alcohol impairment believe that an officer could detect whether or not they're impaired. So there's a lot less belief or faith that law enforcement can detect these individuals if they're actually high and on the road. In part, this varied by how frequent a user they were and how risky of a user. So we looked at these people and classified them in terms of those who would drive within an hour of using. We consider those the highest risk group. Those who would wait 1 to 3 hours, 4+ hours, or they never drive on the same day. What you see in the color coding here is in blue are those people who say, yes, an officer could detect whether I'm under the influence of cannabis. In orange are the ones who are not sure, and in gray are the people who say, no, an officer could not detect if I'm under the influence. So what you see here starting on the left-hand side is those people who were perhaps the highest risk users, they're more likely to drive right after using. Only 21% thought an officer could detect if they're impaired. 60% thought, nope, they cannot tell. And as you can see, this sort of does a stair-step effect that the people who are more likely to wait, et cetera, have more belief that they could be detected by law enforcement. One of the goals of this study was also to look at messaging. How can we get people to be safer drivers and wait until it's safe to drive? And so we did a number of ads that were either adapted from existing messages, which are these that have sort of catchphrases or statements that are consistent with some of the advertising that's out there right now in terms of public service announcements. We added some graphics to make them a little more visually palatable. So we took these four and we also looked at some novel messages. So on the left-hand side, sort of an accepting, hey, we know you're going to use it, just, don't drive if you're going to use it. Some that were a little more hardcore and like, you can't really judge if you're safe, or you may not be the best judge. We're not saying you can't judge, but you may not be the best. Trying to get a little academic that studies show the types of effects that cannabis can have on driving, and then a little more of another hard love message. Let's be blunt. Don't drive and keep everybody safe. So don't drive when you're possibly impaired. And we asked these groups their opinion on these. So going across the top, did they find them appealing, the ads? Did it get their attention? Was it relevant to their life? Did they believe the messaging and the image? Was the image reinforcing? Or did they find it offensive? You know? And there's no sort of absolutely here's the winners. And mostly we're trying to get opinions. There's no real clear winner. We're not trying to find the single best advertisement. But as you can see here, a few stood out in terms of ones that people found most acceptable. They liked the message, etc. And these were the driving high is driving impaired. If you feel different, you drive different, and THC can have different effects on your cognitive and driving abilities. But clearly, it varied by ad in terms of their different opinions on this. The other thing, I know this is very busy, I'll walk you through it, but it's fairly straightforward. The other thing we're interested in is who would you trust in getting this messaging? Do you trust the officer in uniform telling you on, I guess no one watches TV, but on streaming, hey, this is not safe? Do you trust scientists? Do you trust a physician giving you that information? And so across the bottom here is a listing of all the different groups we could think of, from health providers to industry groups, dispensaries, scientific groups, safety advocacy groups, law enforcement, and so forth. So those are going across the bottom. And then in the bars or the columns, we're seeing in green the percent of people who said they would trust this source. In gray are the percent who were neutral on that source, and then red, the percent who said, no, I do not trust this source. The best way we could think of to sort of summarize this into one variable was a net trust score. So across the top here, from +40, +35, +35, all the way down to -22, is simply the difference between trusted minus untrusted. So, healthcare providers were up there. A lot of people trusted the industry to tell them about driving and cannabis use. It's sort of, you can just move down the line. And you see law enforcement was somewhat neutral, but that's where you start seeing a jump in people who would not trust this source, and increasingly government. And, sort of surprisingly, actually, a lot of people do not trust celebrities. They don't trust influencers. So we get all this message that social media, et cetera, has this great impact, at least in our survey. they really don't trust them as a source of information. And this is somewhat the same information, only broken it down by those who would drive frequently after using the ultra high risk, and medium risk. And we're not going to walk through all of these, but the main take home is you can see that for the most part, the more frequent users, the people who are likely to drive after smoking, are a hard crowd to please. So in general, they really don't trust many of these groups. So in red means they're significantly less trusting than the other two groups. In green means they're more trusting than the other two groups. So you can kind of sort of eyeball it and see in general, when you go down these, that the more regular users really believe that I'm the best judge. I don't need people telling me, when I'm safe or not. Okay, I'll just wrap it up with talking about sort of our current projects. So again, I'm very interested in administrative controlled studies. So this is a study we have going on with the DMV, Department of Motor Vehicles, up in Sacramento, and in collaboration with the California Highway Patrol. For this one, we are actually taking people on the road on the test track. So they get randomized to placebo or THC. They drive the test track. The officer follows them around, determines whether or not they would pull them over. Regardless, we'll pull them over, do the field sobriety test. They'll go back to a building where they'll do some of the more advanced testing and really try to emulate the real world process that a person goes through. Our study was just looking at one component, the field sobriety test, and offer is looking at driving behavior and a lot of other factors. So this is a study that's about a third of the way through right now. We're going for 300 people. It's a very large study. And then in San Diego, we're starting a new study where we want to look at high THC concentrates. This is vaping oil or dabbing wax, etc. We cannot study that legally on our campus because of federal laws. So all we could do is do an observational study of people who use the product as they would use it at home. So we're trying to match what we did in our smoke study, and we've put a full-size simulator inside this Mercedes van, have laboratory capabilities, etc., and we'll be driving to their home. They will come out, they'll do pre-testing on the simulator, they'll go in, they'll vapor dab while we watch them on video. They'll come out and we'll do testing over the next 4 or 5 hours, just like we did in the smoke study. Again, try and understand what is the impact of these high THC concentrates and do people self-titrate and so forth. So in conclusion, cannabis clearly can be impairing, but not everyone becomes significantly impaired. The effects are most pronounced in the first couple hours, with them wearing off 3.5 to 4.5 hours. Importantly, users perceive the effects beginning to resolve before they actually do, at least in our study. And experienced users do develop tolerance, but they may offset this by ingesting more THC. When it comes to identifying individuals who are impaired due to cannabis, per se laws are effective when there's a robust correlation between fluid levels and concentrations and impairment. That is just not the case for THC in driving. FSTs do differentiate between people under the influence of cannabis and placebo, but there's a high proportion of non-intoxicated individuals who do poorly on the FSTs. And even though they're designed for high sensitivity, you really don't want to have this poor specificity. It sort of reinforces the challenge when you take group findings, even when it comes to THC and driving. Very clear group findings, but at the individual level, it's not so clear. And I didn't go into it right in this presentation, but confirmation bias is a concern when driving under the influence cases with law enforcement. In our study, of all the people they called FSMP impaired, they thought they were all under the influence of cannabis, but 25% were in the placebo group. And then when it comes to messaging, the most frequent cannabis users are the most likely to drive after use, the least likely to believe that impairments can be detected by law enforcement, and least likely to accept messaging about the risks of cannabis impaired driving. So moving forward, obviously, to reduce cannabis impaired driving, we need a comprehensive approach, accurate information going to individuals who are cannabis users, laws that incorporate robust science and what's been found in these studies and other studies, accurate and validated enforcement efforts, whether it's field sobriety test, oral fluid, etc., and broader public messaging that reasonably convey what are the risks of driving under the influence of cannabis. These are the various references if you want to learn more about our studies. We've made sure they're all open access, so they're freely downloadable. It took a large team to make these studies come to fruition. So this is our administration study team, a lot of investigators and a lot of very important staff. A lot of help from the California Drug Recognition Expert Program. It was funded by the state of California. And these are the individuals who participated in the survey. Again, that was funded by AAA Foundation for Traffic Safety. And with that, I will stop and take any questions.
Thank you, Dr. Marcotte. That was a great presentation. I know I've seen it before, but I always feel like I remember something new now, seeing it a second time. For everyone who has questions, please feel free to drop them in the chat or raise your hand. I do have some here as well. What has the process of informing policymakers been like? Have you found that your recommendations have been implemented, or do you get any pushback? What is your perspective there?
Well, so we've done some briefings for the state of California, and briefings with CHP, some briefings, interactions with national law enforcement agencies. Also, I think one area where we had impact was actually the person who sponsored this bill was a retired CHP officer, a very conservative part of California, and he just wanted to make sure that there was good science out there. Um, and he was very much in favor of per se laws. And I think between our study as well as learning more about the limitations of per se law, California just stopped. Occasionally it pops up, but for the most part, people realize that it's not very useful. In terms of, for example, the challenges in field sobriety tests, that's been an interesting experience. We've had a lot of interest from toxicology groups, from judges, from traffic advocacy in our research. While we've had interactions with law enforcement and NHTSA, who funds the field sobriety test program and the DRE program, none of them have invited us to give a formal presentation to them or their groups. And so it's still uncertain how much our findings are going to actually influence protocol and procedures in these national programs.
Thanks for that. I know that you mentioned Pennsylvania earlier as a zero tolerance state. And currently, there's a significant push in the legislature, HB 878, which I know we talked about before the meeting, to protect medical cannabis patients in the program from getting DUIs. What is the best recommendation that you can give to either the legislature or lawmakers on the that's based on the research as to how they should approach legislating cannabis and driving?
So I think it's clear, sort of my opinion is per se laws are just ineffective and actually perhaps counterproductive in terms of people thinking you need to have above a certain THC concentration to be impaired. You can have low levels and be impaired. Um, so yeah, toxicology is an important component, but it's just one component and doesn't tell whether a person's impaired. I think in terms of field sobriety tests, there are clearly some challenges there. I think they're still somewhat beneficial in that they're giving a standardized approach to trying to evaluate people. But obviously, you can't take them as a standalone. You really need to look at the entire picture of what people see when an individual drives. And I'll just tell you, I've now been in many conferences where there's presentations of sort of the standard information and a body-worn camera, and probably seeing the person actually interact and struggle to do basic things probably has greater impact on juries, et cetera, than necessarily some of these standardized procedures, though I'm completely in favor of trying to make better procedures. And a lot of us are trying to come up with additional instrumentation that could help officers determine in an objective way whether a person's impaired.
Are there any additional, I know with that mention of additional instrumentation, is there anything currently that's gaining traction or any kind of preliminary evidence that is particularly effective?
No. I mean, there are pilot studies that have promise. You know, in part of this study, we did some tablet-based measures that I thought were very smartly done and great hypothesis, and were only modestly effective at best. And so we've revised them to make them a little harder. One of the challenges, if you're going to go in the field, it has to be very simple. Someone has to understand it at 3 a.m., in the middle of the night with cars whizzing by. So you can't do I'm a neuropsychologist, you can't do complex neuropsych testing. Um, and so there's a lot of limitations on trying to do those. So we're revising our version to see if we can do better. There's something called Druid that's gotten some attention, but it's not clear that they have a mechanism to be an in the field thing. Because one of the challenges in the field is you don't have any pre-testing. So you have to know how a average person would do on it. And the more cognitive you get, the more it's affected by age and education and so forth. People have looked at breathalyzers. There's still work going on there. One of the challenges, breathalyzers, oral fluid, eye movements, a lot of studies get a lot of national attention. Uh, Let me take that back. A lot of products get a lot of national attention before there's strong validation that they actually work as intended. And that's sort of one of my pet peeves is, I think people need to get funding for their company. And so they get a lot of publicity before it's really shown whether or not their instrument is sensitive and specific.
Thank you for that. I did want to pass it over to Dr. Wade Dew, who's the co-director for the MCRC. I believe you have a question, Dr. Dew.
Yeah, no, thank you so much. It's a great talk. And as a psychiatrist, I think it is really interesting and to see all the data. It reminds me some of the older studies looking at benzodiazepine and on the impairment. I guess, it's great that we can have a controlled environment and to looking at the driving impairment from the cannabis. But in reality, many of the medical cannabis users, they also tend to have other medicines such as psychotropics. So I'm just curious, have you done any study looking at a combos effect, such as cannabis plus antidepressants, or, especially some people use for pain, for example, duloxetine is one of that. And I remember the packaging insert suggests that you cannot operate heavy machinery after taking the medicine. So I'm just curious about that.
Yeah. Great question. No, we have not. And, you know, there is so much research that needs to be done. But certainly, on the more, I don't know about illicit, but polysubstance is usually what officers find in the roadway. And it could be illicit drugs, it could be alcohol, or they may be prescription drugs. And as you know, there's reason to think there are interactions with some of these medications, and it's on our long list of things we'd like to do. So just need time and money to do them. But it's a very important question. I think in general, prescription drugs and even OTC medications have been under-researched when it comes to the risks on the road.
All right, so I believe I have one last question here, but if anyone does have another question, please feel free to put it in the chat now. Otherwise, we can wrap up soon. What is your opinion on rescheduling and kind of what impact that would have both on cannabis and driving, as well as with access to research and opening that up?
It's really unclear. So, if it gets rescheduled to Schedule 3 or whatever, it'll make some things easier. So we'll have less stringent security systems. So right now it's stored so we go through our investigational pharmacy that has cameras and bolted down safes, etc. I think over time that's loosened and other places may have it in sort of a secure room, etc. So it's not as stringent. It used to be in our early studies in the 2000s, they wanted us to bolt down a full-size trailer, like an office trailer, and it was crazy. Now it's much more reasonable. But yeah, the fact that we'd have less security, it might be easier for people to get a Schedule 3 license or registration to do that research. That would be helpful. But if you're still having a situation where it still has to go through the DA because it's still scheduled, it's just a different schedule, it doesn't resolve the issues we have with the FDA, where the FDA wants to use we want to use some products and the FDA says they're not good manufacturing practices, et cetera. So my best guess is that actually reschedule it would only have a modest improvement of being able to do this research. What we really need are more products like the real world under good clinical manufacturing. The companies that were approved to do that really aren't doing that. They're tending to focus on different medicinal products or things that might have intellectual property because they have a company that needs to make money. Quite often there's not placebos with that, et cetera. So rescheduling, I don't think on the research side would have profound effects. I think it'd be helpful, but not a game changer. Yeah.
Great. Actually, we do have one question from the chat for our last question. Kushal, one of our project managers, asked, I noticed that all forms of outreach or communication seem to be less effective on the most frequent cannabis users. Is there any idea at present how to more effectively reach that group?
Not really at this time. Oh, go ahead. Sorry. Okay. Yeah, okay. No, that's fine. Not really, at least not with our group. So, we're also reaching out as you know, other states, Colorado, et cetera. Everyone's trying to come out with new messaging information. To me, what I think is needed is really even more of a deep dive on the very frequent users, et cetera, the motivation, and really understand better those folks, right? Some of them may be using for medicinal reasons and chronic pain. Some have an addiction. Some people, there's many motivations what people use. And I think really understanding probably how to personally personalize the messaging to different groups. It's probably not just one group of very frequent users. So.
Thank you, Dr. Marcotte, for answering all of our questions and giving this great presentation. Thank you for your time. And wanted to give a big special thanks to all of the work that you're doing within this space. And thank you to our team for some great questions as well. Look forward to following your work and staying up to date on all of the new work that does need to be done, as mentioned before. So thanks again, and hope you have a great start to your summer.
Great. Thank you for the invitation. I enjoyed the interaction with you guys. Take care.